Good afternoon, good morning, good afternoon, and good evening. My name is Glenn Roil. I'm based in St. John's, Newfoundland. I am the co-lead of the Americas regions for the Global Mental Health Peer Network. We're having a discussion today dealing with social determinants of health. I will turn it over after a land acknowledgement and a slight prayer for, as a global community, acknowledgement to the Indigenous groups of the land that we are presenting today, as well as a prayer of the wisdom and the insight that each speaker brings today. And hopefully there's action that comes out of this with governments, communities, and other stakeholders. With that, I turn the first part of the presentation over to Charlene, the founder and CEO of the Global Mental Health Peer Network. Charlene, the floor is yours.
Thank you so much, Glenn. Can you perhaps go to the other slides? Yeah, so we're very fortunate to have our Americas team organize this interesting and very important discussion around social determinants. Just next slide. So just to give an overview of the Global Mental Health Peer Network, are represented by people with lived experience. We have currently around 140 experts by experience across all 6 world regions. You can see here on the map which countries are represented. And the next slide, just see some of the statistics of our member profile. We really pride ourselves in taking equality in every aspect serious. So we always make sure that our global representation reflects equality in terms of gender, sexual identity, ethnicity, age group, and demographics. And you'll also find that our membership has a diverse set of skills and experience. And that is very important when we speak with one voice to get to common goals that we want to achieve. And you'll see here from the diversity across the different areas is why it's so important to speak collectively on issues related to social determinants, because we all have context-specific experiences around mental health and other areas that affects mental health. Just to highlight some of the statistics here, you'll see that quite a large number of our membership are between the ages of 18 and 34. Interestingly, majority of our membership are female by 62%, and across ethnicity, we also quite well represented in terms of that. In terms of the demographics, what's also interesting to see is that just over 50% are from the African continent. When you consider that stigma and discrimination is also rife and also one of the social determinants, one would actually think that Africa being more made up of middle income countries, so it's good to see that there's that large number of representation. We also well covered in terms of income country, from low to high income countries. We have grown over the last, I would say, year or two from low income. We did struggle a bit in the beginning, and that of course also has its own possibilities of reasons. Social stigma and discrimination, for example, poverty, all those could affect representation as well. Our members, as I mentioned, with diverse set of skills. You can see they work in various fields, but the majority are activists and working specifically or primarily in the advocacy domain. Next slide. Just to explain briefly, kind of the core function of the peer network, there's 2 purposes that we fulfill. The first one is to provide an engaging and safe platform for people with lived experience to share their experiences, views, opinions, but also their recommendations, and also to learn from each other, also to support each other. How we do that is where our members collaborate. This is actually a prime example of specifically that, where our Americas team came together to put together this specific webinar on a topic that they felt is important. Networking, our members network with each other. And we also have discussion platforms. We use WhatsApp, for example, where all our members participate in discussions, but also support each other. And then, of course, one of the most important functions is to empower our members to become leaders in mental health and advocacy, both at global and local levels. The whole idea and the impact that we achieve through our work is to place people with lived experience central to change and transformation in mental health, and also to have an established human resource hub where we have diverse lived experience expertise that actually could help influence policy in practice, and also coming from specific country context. And then also to amplify and strengthen the voices of people with lived experience globally. Next slide. Next slide. And then just to look at the fields of expertise, I think a large chunk of our work focuses on advocacy and awareness, and that is with the aim to influence policy and practice in mental health. Empowerment, where we build capacity and leadership among people with lived experience, and engagement, which we do through providing consultancy services through lived experience expertise, which our Deputy CEO, Claudia, will speak a bit about later. And then we also contribute quite a lot to research, both as non-academic lived experience perspectives, but also some of our members do have research and academic backgrounds. And then human rights, we integrate across our work, but we also advocate for human rights to be across what we do. I hope I didn't take too much time, and I'm going to hand over back to Glenn, I think. Thank you very much.
Thank you, Charlene, for that presentation. Yes, I will just give everybody a brief definition or an oversight of what social determinants of health is for our discussion. Social determinants of health is considered the non-medical interventions that keep people healthy and well in their communities. Some of those aspects are anywhere from income to employment status, educational opportunities, housing and food security at all, as well as the other parts of environment and genes and the other part of the medical system sort of thing. Next slide, please. As many people who may be seeing this webinar here in the province of Newfoundland and Labrador might have seen this document from the Health Accord that was facilitated by the government of Newfoundland through two incredible individuals. And it shows that the biggest chunk, what makes Canadians and global citizens sick, is those social determinants, as I've just elaborated. We can also talk about gender, as well as safe environments to be living in, people with various disabilities, and early childhood interactions in terms of trauma and so on and so forth. That's more than 50%. 25% again is the access to healthcare wait list and other aspects in the healthcare system. Your biology, as I said, from genes only makes about 15%, and 10% is the environment, even though it's a very critical piece. So that's generally the overview of what social determinants of health. With that, now I turn it over to Larry for his presentation.
So good morning, good afternoon, good evening, wherever you are. I'm honored to be joining you from Chief Dry Geese Territory on the traditional unceded homeland of the Yellowknives Dene Nation. My name's Larry White, and I live and work in Yellowknife, Northwest Territories. Drawing from Indigenous ways of knowing and being, I find it important to situate myself for this conversation. I'm an educator, and I spend my time trying to find ways to help others achieve their dreams. Part of that materializes in connecting the dots between learning and other aspects of life that affect learning, and more importantly, the ability to learn effectively in a manner that works for each person individually. I don't by any means consider myself an expert on either educational determinants of health or mental health, or the intersectionalities created between the two, but I've worked in management and leadership roles in a variety of sectors over the past 40 years, in post-secondary management and leadership for the past 22, and have been learning to live with my own experience of moderate to severe depression for the past 7 years. In these most recent years, I've become an advocate for learners' voices and for the value organizations might gain by learning from lived experiences. Because my experience is Canadian, most of my remarks in the next couple of minutes will share that context. I'm here today to speak to the educational determinants of mental health. And given that the majority of those currently pursuing educational opportunities are adolescents, I'm going to begin with a quick overview of who these folks are, typically referred to using the name Generation Z or Gen Z. Generation Z are young people born between 1995 and 2010. They're arriving on the world stage as they collectively participate in post-secondary education and in the workforce. And as they begin to qualify to vote and occupy leadership roles in governments, businesses, and non-governmental organizations, NGOs, they're going to chart the course for humanity and the planet. They're the conduit for future generations. We often refer to the Gen Z as digital natives. They've always been connected with essentially ubiquitous access to the internet, mobile communication technology, cloud computing, and social media. They grew into a world that's always been turbulent. For example, the war on terror, the Arab Spring, the spread of jihadism, and the rise of populism all around the world, amidst a global recession and facing a climate crisis. Their world is characterized by rapid change, and they adapted to this as their way of life. They are neither temporally nor geographically limited, and they know that their work is essential and they want to make a difference in the world around them. Then the world changed. COVID-19 directly affected the learning of over 1.6 billion learners in more than 190 countries, along with educators, families, and all of society. This quote that's on the screen from Parker and Agilnik sort of sums up the challenges ahead for Gen Z, which, according to the United Nations, holds the burden of carrying forward the collective global wisdom to future generations. In the Global Citizenship Survey conducted in 2017, believed to be the most comprehensive study of its kind in recent years, they explored the happiness and future outlook of those in Gen Z. Broadbent and colleagues reported that the overall happiness of adolescents is 59%. And as the first figure on the screen indicates, young men tend to self-report as being happy at 62%, more than young women at 56%. On the surface, this seems optimistic, with 6 in 10 young people reporting happiness. However, as shown in the next figure, happiness is inversely correlated to their age. In fact, with a robust negative correlation between age and happiness, the rapid decline of happiness as young people age is troubling and speaks to the need that for us to concern ourselves with the educational determinants of mental health, particularly for this cohort. As part of the survey, young people globally indicated that money at 56% and school pressures at 46% were their most significant anxiety-inducing factors. These are reversed for Canadians in Generation Z, with school pressures at 63% and money at 56%. Of the countries included in the Global Citizenship Survey, young Canadians' citing of school pressure as the most significant contributor to their anxiety at 63% was second only to South Korea, where young people rank school pressure the highest at 70%. This appears incongruous, if you think about it, given that Canada and South Korea position among the top 10 performing education systems globally. Additionally, while ranked as the lowest contributor to Gen Z anxiety, access to basic needs such as food, water, and shelter at 10% should really be concerning from both mental health and global humanitarian perspectives. So Gen Z's world is also experiencing a growing crisis related to mental health, to which their cohort, today's adolescents, are the most susceptible. They're the most affected cohort. In their Youth Voice Report 2020, Jack.org gives voice to the voiceless by summarizing the prevailing concerns of Canada's post-secondary youth, specifically to inform and guide post-secondary policymakers and administrators as they address the mental health care needs of learners in their sphere of care. Canada's youth understand their role as the primary stakeholder in their own mental health, yet almost half of young Canadians feel they're not consulted regarding decisions that affect their mental health. The absence of a clear pathway to such services and supports causes youth intense pressure. As illustrated on the screen, 94% of post-secondary youth in every region of Canada believe that academic stress leads to mental health challenges that they and their peers are experiencing. This presents an even more alarming situation than the Global Citizenship Survey suggested, perhaps due to the onset of COVID when Jack.org conducted its Youth Voice Report survey. Underscoring the urgency posed by this statistic, and even more alarming, is the increase in the contemplation of suicide. Since the onset of COVID-19, suicide ideation for this cohort tripled to 18%. These are Canadian numbers from 6% previously. And this rate is typically much higher for at-risk Indigenous and LGBTQ2S+ youth. Historically, in Canada, most universities were influenced by British and French colonialism and through the involvement of the churches. They were accessible by what I'll call the upper class in society. By the 1960s, however, most universities adopted a more secular governance model, allowing them to better tap into and capitalize on funding opportunities. Now in Canada, the separation of church and state is really quite well established. The university sector experienced tremendous growth in Canada during the latter half of the last century, with associated increases in the number of universities and the population engaged in university study, as well as the beginning of the community college system. In fact, this growth was so successful that today there are proportionally more Canadians with post-secondary credentials than any other member of the Organization for Economic Development and Cooperation, the OECD. However, in recent decades, neoliberalism, which is the commercialization and commodification of post-secondary education, has been promoted by a systemic and ongoing decrease in public funding, which has shifted the primary focus from teaching and learning to marketing, competition, and the retention of fee-paying students. This change required universities and colleges to reallocate resources from a process that viewed access to knowledge as an intangible good toward determining how to sell and profit from their product. This incremental change has, in my opinion, restricted colleges and universities from striving for excellence in pedagogy and curriculum and educator capacity to support the diverse needs of learners. Instead, it's made them and their learners more susceptible to the various drivers and causes that influence the effectiveness of learning and teaching. So this one is a really busy slide. So I'm going to break it down for you, and to a certain extent, I've been building up to this. There are underlying drivers that affect all of us. These include broad global challenges and issues with which the world is currently seized, though many might say less so than what we should be. Underlying drivers include climate change, for example. This is leading to widespread sense of eco-anxiety among the world's adolescents and fostering a sense of betrayal by adults, particularly governments, for not adequately addressing climate change. Over the past 3 years, we've also experienced the devastating effects of a global pandemic, not only on access to education, but on everyone's general feelings of safety and security, as well as on their mental health and well-being. I could also talk at length about the concept and effects of colonialism, intergenerational trauma, and other forms of oppression that learners experience from numerous sources and that continue to compound injustices from the past. There are also drivers that are specific to the model of education that we have. As I said a moment ago, it's rooted in colonialism with values and practices that support those who are traditionally representative of the dominant culture in society. For example, when learners are unable to see examples of people like themselves in the curriculum and in teaching practices or pedagogy, with which they're interacting, it can act as a barrier to learning and as a catalyst to fostering mental health challenges. Likewise, if an instructor fails to create a safe, open, and inclusive learning environment, this can seriously affect a learner's sense of belonging, which is critical to good mental health and the relationship between themselves and learners, often viewed as the single most important element of effective learning. Proximate causes are those close to and unique for each individual learner. As discussed earlier, 94% of post-secondary learners in Canada experience academic stressors that are pronounced enough to adversely affect mental health and well-being. When compounding this with issues related to personal finances, family and peer relationships, and lived experiences of racism, stigma, and other forms of oppression, the effect on a learner's mental health may become more pronounced and more serious. Of course, there are mediating factors that depend on the individual and their environment, and they may moderate the effects of other educational determinants of mental health. For example, if learners feel supported by family, instructors, or culturally, it may mitigate some of the adverse determinants as they help to build resilience and a more positive self-identity. I want to say thank you very much, and I'm turning the mic over to my colleague, Dr. Kriti Vashisht.
Thank you so much, Larry. Hello and greetings to all. My name is Dr. Kriti Vashisht. I am a faculty member in the Department of Psychology and Counseling in University of Louisiana System. Clearly, my slide is a representation of my lived experience as an immigrant in the US, but also as a professional who is interested in intersectionality of social, cultural issues and mental health. Primarily, I am working towards how mental health and climate change, how mental health and violence, and how mental health and migration are intersecting and integrating with each other. So, when we talk about migration or when we talk about mental health, we already know that how complex in itself these both topics and construct are. Migration, and when I say complex, I'm talking about how migration is a result of so many social, cultural, political, psychological standpoints and factors. And similarly, how mental health is also an outproduct of n numbers of social, cultural, political, and psychological factors. When we talk about such complex topic, it is very important. It was very important for me to focus more on my lived experience, to give more discourses in the field of academia and maybe in the field of to the audience, that how mental health and migration can also be understood from a social, cultural, political perspective, from an immigrant perspective. And I also wanted to add my professional perspective, because my lived experience has greatly impacted how I engage with migration issue and mental health in my professional setting. So that's why it's personal and professional. Now, when we talk about my lived experience as an immigrant in the US, I would want to specify that how my immigration journey is very particular to my experience, and it is different for different people. So that is clearly one thing that I would like to put forth. And why I say that, because my immigration journey was a result of choice, was a result of my intention for better opportunities, and also was supported by my family. Having said that, the immigration journey hasn't been a bed of roses for me either, but I wanted to discriminate or differentiate between my immigration journey as compared to forced migration or displacement, which I might be talking about in my professional perspective. So when I talk about my personal perspective, as someone who is passionate about a topic, a career, I wanted to move to the US for the quality of education and n number of experiences that I could get. But the moment I reached the US and I started my educational journey, I realized that how the policies are so restrictive for international students that we are not allowed to work more than certain number of hours, and we were also not allowed to go and do internship and other kind of opportunities, especially learning opportunity outside the institute that has sponsored our immigration. So that was definitely one point where I realized that I took such a big leap in my career, and here I am so restricted to one department, and and I need to make sure that I'm working with whatever resources I have in one. So that was restrictive. And even if I was doing a terminal degree, that yield a lot of a blame and guilt related to how I should be approaching my career in terms of a PhD student. Next come the cultural and social navigation, and how it is different in India and how it is different in the US. And it is very particular to the department I joined. So in the department that I joined, they wanted students to reach out to them and maybe engage in the research and the project that they are doing. But I was so overwhelmed with the idea of living in a different country. I didn't even realize that what and how and where should I be starting. So for one good year, I was just trying to track when sun comes up and when sun goes down, because I was so physically and mentally overwhelmed. And that did not yield a good result in terms of how I should be mentored and how I should be communicating with my professor. So when I said that, that was a point when I was struggling with something, because this is something that I never knew, that migration and a different system could have impact my physical and mental health more. And the third point that I would want to talk about in my personal journey is job and immigration. When I started looking for job, immigration policy in the US is so segregated for particular community, especially immigrants, that they are not allowed. Sometimes their application is filtered just because they need sponsorship, especially after the political unrest that happened in 2016 in the US. So that was a struggle. I started applying for job 2 years prior to my graduation, and I got the job when I was 1 month before my graduation. So it has been such a traumatic, stressed journey to find a job and to prove yourself as an immigrant in a different system. I thought after getting a job, that's the stop to my journey. But then navigating your own academic journey is also a task, because sometimes people believe that because of your immigration journey, they can subjugate you, they can use you as a resource, but also you will not go against them because you need that kind of immigration support. So that also leads to a lot of stress and mental health concern. That's my lived experience. Quickly about my professional perspective, for my PhD research, worked with women violence victims, and the agency I was working with, they were serving Latinas and Hispanic women from Southeast Texas. I struggled a lot to retain my participants because it was a vulnerable population. And secondly, I wasn't able to recruit the participants because most of the women there were undocumented or maybe were on some visa, and because of the intimate partner violence, now they are maybe illegally living in the US. So they were not very open about their intimate partner violence journey. So when you combine your immigration and politics with mental health or violence, it gets so complex that the kind of help that's required for that community is definitely mental health, but they require a lot of collaborative and integrative work when they do. So the agency was working a lot on their legal needs, their social needs, and their educational need, and the mental health needs. Recently, I am also working with a professional group where we are criticizing. When we say criticizing in a positive way, we are criticizing the set crisis framework for the migrant population, especially for Ukraine migrants, because when UN, a big organization, employed people to help migrants, especially in crisis such as because of war, their focus is on trauma. But when you are on field, you will realize that trauma is something that these community need, but there's more than trauma that they want. And the crisis framework that we are using right now might not be fit for this population. So, creating a space where you are including lived experience voices, or a space for communities to even criticize these kind of crisis framework is required. A lot of work in migration and mental health requires clinical work, definitely clinical mental health work, but majority of work should be done in terms of advocacy and policy and community engaged research. And this is something I am pushing forward from what I have experienced as a professional as well. So these are a few points that I wanted to share in my presentation. I would want to forward this presentation to Anne, my wonderful colleague, and will share her experience with us. Thank you.
Thank you. I'm Ann Kasper from Oregon in the United States, which is on the West Coast. I'm a self-identified geek and tech enthusiast, and that's why I'm speaking about data today. I'm also a peer support specialist and a foreign language teacher. 30 years ago, I helped 900 refugees come to the United States as a refugee resettlement coordinator. So I've been with for 30 years and know that the generations and getting data from generations is also very, very important. And I'm also the Portland Community College chair of the Addictions Advisory Committee. Addictions and mental health go very hand in hand, and we should all be working together. And a person with lived, and I like to say loved experiences, because I'm not just those hard experiences I've been through for my life in the mental health systems, but I also have great things in life that have happened with me. I'm speaking about why is data important for social determinants of health. It's because without data, how will we know what they are? How will we know what's going on in the countries? And as a peer, it took me 8 months to get on what's called in Oregon here, the Health Information Technology Oversight Council. Now, that is the council in our state that decides how health technology is going to be used and implemented and planned here. And it's so important that peer voices are at those technology discussions, because we add different kind of perspectives and think on things. One of the perspectives is about questions. What questions do we ask on which data to do? CIE, as mentioned here, there's a link in the slide here, which is a community information exchange, is one of the projects that the HITALK, I like to say, I'm on HITALK, not TikTok, right? HITALK, the Health Information Technology Oversight Council, does. And that is a community information exchange, meaning that it is a data exchange between mental health providers, food bank providers, any kind of social service agency, and they will have one line where they can keep information about one person and what kind of services they get. I'd like to read the vision of the Oregon Community Information Exchange work group. All people living in Oregon and their communities have access to community information exchanges that create seamless, trusted, person-centered connections and coordination to meet people's needs, support community capacity, and eliminate silos to achieve health equity. And I like to add as a peer, person-directed data as well, not just person-centered, because if it's just around us, people are speaking and writing about us, but we have our own voices in the way we see things as well. And when I held public information sessions on this with the mental health community and the addictions community in Oregon, we found out that HITALK had forgotten to ask us to be at the tables to help prepare these things for CIE, for the Community Information Exchange. And without our perspectives, they didn't think about the possible consequences of having data out there about us, about our mental health statuses, about our addiction statuses that may actually hurt us. Could we get the next slide, please? So the two different kinds of things are Community Information Exchange. There's also HIE, Health Information Exchange. So that is the storage of data. For example, if we're in a mental health hospital, they will write about us, right? Or we even do peer work, they write about us. That's held in these information exchanges. And as peers, I always encourage us to think about what is written down, how is it written down, how is it kept, because this information can affect us the rest of our lives. And it's so important for people, even in younger generations, to think about what is written about them in whatever system it is. And so we have the community information exchanges in Oregon, which are just starting off, and the health information exchanges, which have been going on for a long time. And social determinants of health, without collecting that data, how do we know what is going to be worth looking at? I have a few asks for systems people, because I understand on this webinar, there's some people in the political systems watching this, and when you're working about tech. So number one, please have peers at the tech committees. And we also need a way for peers. There's a lot of peers. Peers can be anybody. And there's a lot of peers really interested in technology peers who know what the technology is and just need to be asked to be on there. Let's make that path easy for them to be there. And we as peer supports also support them on these committees. Number two, when you're asking for data of these social determinants of health subjects, make sure that you have permission from the person that you're taking it from. And let them know how that data is stored, where is it stored, and how they can obtain to be able to see it themselves. And a very important thing too, when you're collecting this data, let them know why and give them information how you used it to make policies better. How did you make this program better with this information? And a very important thing as well is please use peer academic researchers. There are groups of international researchers like Kriti at the academic levels doing research. We ask different questions than the people who are generally at those tables before. And make sure also that your questions are culturally sensitive to anybody that's being asked from them. So those are a few points to think about when you're using data. Social determinants of health are very, very important. In Oregon, we are basing all of our mental health and health equity on that, our systems. And it's a bit messy right now because it's all good. It's going from an old way of thinking to the new way of thinking. and we're learning a lot and looking forward to hearing the next person. Thank you. That's Claudia. Thank you.
Thank you. I'm really glad that I'm actually going after you, because saying, just saying what you've said about the data and having people included in there, especially peers, it filters quite nicely into what the peer network does in terms of lived experience and mental health. So us being part of engagement sessions and reviewing of policies, discussions at higher levels, at conferences, it's important that we're including lived experience, which in this case would be peers, right? So my discussion then filters through in terms of our employment as peers with lived experience, and how does the world view us? So we have come now to the point where we understand that lived experience expertise is valued and it's necessary, and all our stakeholders, ranging from governments to research organizations, academics, corporates, etc., are including lived experience in these in services, right? But now what we're really wanting to see is we want to take it a step further in terms of our advocacy and start saying, okay, so we don't want to just be seen as volunteers anymore, because that's not what we do when we're really getting involved in making or providing inputs into policy, right? The value that we hold is really important, and it holds a lot of weight. So we would like to see the current compensatory practices being replaced by remunerated engagement, consultation, increased financial support. Right, going back to income. Income is part of the social determinants that we're talking about. It's part of how we live our lives, or the quality of our lives. So if we're doing this all for free, while it's great and we're giving back, we're also not able to live, right? And it's our right to live best, given our circumstances. So I think it's really important that we're bringing in this aspect into today's webinar. And I thank you for including me in this particular determinants into the discussion. So like I said, despite the global emphasis of the importance of the voices of persons with lived experience, the thoughts of lived experience as service providers or delivery of services, it's still not at the place where it should be, particularly within the lower middle income countries. I'm not at all excluding the higher income countries, but I think it's important to note that it's predominantly within Africa, for example, because of the notion that if you have a mental health condition, it's impossible that you can perform duties. So you cannot be employed, therefore you cannot be paid, etc. So there's that vicious mindset, and we're advocating for changing that the mindset, for shifting that mindset. Next slide, please. So like with anything, like Anne was saying, we need to rely on data, and data is a really huge resource. We can't do anything without that, right? We need to be able to, as advocates and as peers, know that there are human rights instruments that are there for us internationally that we must rely on. They're there for a reason. They're there to protect and promote our human rights. So we've got, so I'm going to go through a few of the rights instruments that we rely on at the GMHPN. But the idea is that there's this call for equality and recognition of all people, including people with psychosocial disabilities, towards advancing the socioeconomic sustainability. Right? So now we're looking at not only our experiential value, but our monetary value. What can we give back to the community, and what can the community give back to us? So the World Health Organization last year developed the World Mental Health Report, Transforming Mental Health for All, and that report specifically notes that people with lived experience are key stakeholders in mental health. Their participation is vital in improving mental health systems, services, highlighting services, as well as outcomes. Should we then be ignored? Should we then not be seen as valued members of society with, high valued inputs and perspectives? And we're really part of decision-making and service provision. So the two need to be connected. And we've got a international report from the WHO saying this is in fact the truth. So if we're advocates that are not speaking up and making use of these resources that are available, advocacy is never going to kind of proceed. So we need to be confident enough to refer to these documents and advocate accordingly. Next slide, please. Okay, then we've got the International Covenant on Economic, Social, and Cultural Rights. Article 7 particularly speaks for equal remuneration for work of equal value, without the distinction, so without discrimination, without distinction of any kind. So looking at the principle, which then comes back to the principle of equality as well, equity, equal pay for equal work, basic human rights, and a really important principle. The United Nations Conventions of the Right for Persons with Disabilities also says, and protects the key principle for the remuneration of people with disabilities, and that includes us with lived experience. It promotes accessibility to the labor force and the opportunity to have a living, which is what we were talking about earlier in terms of income as your social determinant, and to be in a work environment that is both open and inclusive to persons with disabilities. So we're going into equity, we're going into dignity, we're going into human rights and equality. So we're not at the point when we're only advocating for equality, but we want fair practices and fair processes. So we go into equity. Next slide, please. So to go back to the CRPD, it reiterates the rights of persons with disabilities have been identified as a milestone in human rights protection, offering people with psychosocial disabilities the opportunity, and this part is very important, to hold their governments accountable for the realization of their rights. So the member states that have signed this convention, those countries should all be accountable to protect our human rights. So again, saying that we have a really important document and convention that speaks for us. So let's not be scared to use it. Next slide, please. Right, so what we've done at the network is we're saying, yep, we have the experience and now we're going to share it. So we've created expert by experience services. And I won't go into each of them, but you can find this on our website. I should have put the QR code here. I apologize for that. But Zach, if you can maybe just put our website into the chat for people, for the attendees. But basically what we're doing is we're going to the different stakeholders and we're offering our support and our services as consultants, peer workers, peer researchers, we guest lecturers, we're speakers, and all of this is to empower the people with lived experience. So each and every service that we offer, we will always include our members. So what we're doing there is we're creating empowerments, we're developing leaders across the world, not forgetting that also they should get paid for their work. So I'm going to be that person that's going to remind everyone about that, and that's okay, I'll be that person. So this is just a little bit about what we do in our services. I would encourage everybody to have a look at it. Next slide, please. Oh, I'm done. Is it me? Yes, I'm done. Okay, sorry, I thought I had one more slide. Thank you so much.
Thank you, Claudia. We'll turn it over to Laura now for her presentation.
Well, good morning on Pacific Northwest and beyond every other time zone. Good afternoon or good evening. I want to call out Glenn Roil for leading the efforts in this, what turned out to be kind of complicated for some people, which is defining what social determinants of health mean and then really breaking it down to some practical levels so that each of you, including all of our participants today, could find a kernel of involvement or engagement that might be of interest to you so that we can start impacting the status, the health status, both behavioral as well as physical, among each of us who are peers in this world, struggling to stay alive and struggling to be engaged in our future. So long comment there, but very important. My task was to look at peer support. Peer support is really a modality, by which social determinants of health can come alive and be activated within our community. I wanted to take a look at peer support mostly because it's fairly common across all countries and sections within the Global Mental Health Peer Network. And when I joined, which was a little over a year ago, I realized that there were some things that we could really talk about that we have in common. Lived experience is definitely one arena, which many of us have a lot of experience, but also peer support and all of the peer services that come under peer support across our networks and within our communities. So I wanted to let you know, I pulled these links together. If we could share screen, I'd like to click on a couple of them, if that's okay. Is it shared now?
Well, the presentation is shared. If I click on a link, I don't know if I'll get back to the presentation simply, but we can try.
Well, I know I clicked on, let's see, I have links within my computer. If you shared screen, I can get to them, I think, on my computer. I've opened them up on my computer. Which
So
do
you
you
want me-
prefer?
Doesn't matter to me. I can click a link here too.
Yeah, why don't you try, let's see, Office of Recovery, SAMHSA. I wanted to point out that in the United States, do you see that one? Great. Yeah, I downloaded them on my computer, so I have them. Okay, you've got access. Okay, well, I
Wonderful.
wanted to let people know that in terms of peer support and advocacy, which is the #1 arena for peers that are involved within the Global Mental Health Peer Network, we worked really hard over the last several years to establish an Office of Recovery within our federal government. And this is really a product. If you could page down a little bit, Larry, I just want to point things out to people. There are resources here, staffing. You could see under staff, if you were to scroll up and pause there, it's actually been staffed with a whole host of individuals, which is really phenomenal that our federal government was able to bring together a large budget. And if you can put page back up, please, with a very wide scope. Here are the bullet items that kind of concretize some of what this particular office will be doing. And then if you can go back, I wanted to point that out because peer support is now an evidence-based practice, which a lot of people struggle sometimes with this definition. But it really means that we're able to consider this to be an area that where research can be done, where we can develop new models that are based and rooted in peer support. And then if you can go back to the other list of all of the links, please. I'd like to point out the launch, which is the second from the top, launch WHO framework of meaningful engagement. This particular milestone occurred, I believe, a little earlier this year. And if you could page down beyond the colors, there's a title of this around engagement of people with lived experience across a whole host of really important areas that affect our lives, but also impact social determinants of health. And I wanted to just page down on that as well and have people, maybe if they can, go down the list and take a look at the various opportunities. Now, I only had 5 minutes, but what I wanted to do, I'm going to do this myself. Late last week, our Surgeon General for the United States wrote an opinion piece that I'm going to put in the chat box, and it's a really beautiful, important document. That it was an opinion piece in the New York Times, and I'm just going to get the see, how do I get how do I go back to my page? Let's see. Oh,
If you like, Laura, we can maybe assist and get it posted in the chat during.
I have
during
it.
the,
Just a moment,
okay.
please. It's just a matter of being able to do this myself. So the name of the article, which I encourage you to take a look at, is Surgeon General, we have become a lonely nation. It's time to fix that. And I've included the link. It's the New York Times, so you might need a subscription or find someone. If you would like, I can actually gift the article. They have opportunities now for people who subscribe to give articles as gifts for people that don't have a paid subscription. So feel free, I'll put my email in the chat if you would like it and can't access it yourself. I'd be glad to send it to you. It is that monumental, I think, and moving of an article in terms of the subject matter that I really encourage you to take a look at it, because really during COVID, our world's changed, and peer support and other modalities now are really becoming top of the line. In addition to that, we have a new crisis system called 988 instead of calling 911, which brings upon sometimes the intervention by police. We have 988, which is a new crisis line that's open to the entire country now. And our crisis services are now being staffed by people who are peer specialists, who have a peer credential, if you will, and are working to help ameliorate crisis and provide more humane interventions that could include alternatives to clinical services such as hospitalization. So peer support is now really ballooning across the world. Very excited about how behavioral health care is now on top. We have a lot of trouble in terms of homelessness, but we also have some incredible evidence that's been shown to be effective, which is peer support, and we're helping to illuminate that throughout the world. I want to call out all of these links. These links, I kind of fell into them myself and did some study and research on them. And rather than get too much in the weeds, I just want to let you know that they're worthwhile, and hopefully you might be able to gain some additional knowledge yourself. So thank you for the time, and I look forward to your questions.
Thank you, Laura, for your presentation. That's all. I very much appreciate it. To finish what Laura said, I did see the interview with the US Surgeon General on the issue of loneliness. Please read the article or view the media interview at all. It is a crisis, and I know in Japan many years ago, the government implemented a ministry of loneliness because of knowing of social isolation, and this pandemic has really brought that to a forefront. So with that, I know we have limited time. To our attendees, either through Zoom or on Facebook, if there's any questions, feel free to open up for discussion now. So nobody wants to be the brave person out of the gate sort of thing. So any of the presenters like to offer any more insight or anything else in their presentations while people ponder questions?
Well, if it's okay, I might add this, since I don't want to take up too much. We have time limits, but this is really important, and that is that in terms of global determinants of health, we've really got to look. I didn't mention suicide and issues around suicide prevention, but in addition to that, there are statistics where people with behavioral health care issues actually live the extension of our lives are cut short, which is due to a whole host of issues in the behavioral health care system. And I think there's a strong effort to expand. People who have behavioral health care issues are likely to die 25 years younger than their counterparts. And there are a lot of issues around how to prevent that and look far deeply into the social determinants of health regarding causes. So I just want to bring that up, especially with Mental Health Awareness Month and Week, that we take a look at those issues. And I think that a lot of people are not doing research on that. And if anything, maybe we'll be the ones that have to sort of stand up and advocate that there be research and certainly more interventions created to help look at that figure. So just a plug to do more work on that issue. Thank you.
Thank you, Laura. Any questions from the attendees, either in the chat or would like to come online? Well, we've kind of come to our hour of close. If there's no other people who would like to offer any insight questions or anything, again, thank to everybody who presented today. Any more information about the Global Mental Health Payer Network can be found on their website, sort of thing. And every spring in April, there's a call for new members, especially in the area of our region, especially Latin America and South America, where we're lacking members, or again, globally across the world. It's great work. I've been a part of the network for a number of years through my global award-winning advocacy, recipient of the 2021 Human Rights Award champion from the Government of Newfoundland Labrador Human Rights Commission, and I'm the only Canadian to receive the National Alliance on Mental Illness 2022 Lionel Aldrich Champions Award. Continue to plug through. Mental health is an important aspect, not just on these awareness weeks, awareness months, awareness days. Make mental health 24/7, 365. Push with your politicians, with your stakeholders, with your community, with your business, because mental health is the biggest public health and public safety crisis we've currently got going in the world. Again, thank everybody for their time. And good evening, good afternoon, and good morning, wherever you are. Thank you.